Hey, so I wanted to talk a little bit back on the subject of management of cardiac arrest and the stuff that is outside the ACLS things that we normally get kind of taught. And we're going to stray a little bit into the trauma realm, but I'm going to call this still primarily cardiac arrest in terms of the subject matter. But let's talk a little bit about whether or not you treat somebody who died as a result of trauma the same as somebody who dies as a result of medical out-of-hospital cardiac arrest. And again, we're looking at this in the EMS realm, in the field realm, not so much when you get into the hospital itself. So, does trauma arrest equal medical arrest? It's often kind of taught that way. Many places don't have a specific trauma arrest protocol. Some places do, but many places you're going to be doing the ACLS stuff for the trauma patient the same as you would as for the old gentleman who had a heart attack, clutched his chest, and fell over dead. You're going to be doing the same interventions. I would posit that the same interventions are not the same and is not of equal value anyway, and that we probably ought not to be doing some, but maybe there's one that's really important, maybe in some cases. Anyway, let's get to it. Real quick, why does ACLS work? When we push on somebody's chest after cardiac arrest and we ventilate them and then we shock them and we give them drugs often. ACLS is predicated on the idea that it is primarily the pump that has stopped working. So the heart has stopped squeezing for whatever reason. And if we can sort of supplant that by doing chest compressions, then we may be able to maintain life throughout the body, at least maintain the brain and some of the other organs while we try to figure out why the heart's not beating or what we can do about it, which we give drugs for. So ACLS requires intact vasculature, intact valves in your heart so that you don't get backflow and that you actually get forward flow of the blood, and intact volume, because if you just squeeze an empty heart, then you're just squeezing an empty heart. You're not actually causing anything to flow forward. So vasculature, valves, volume, that's why ACLS works. And you have to have all three of those things intact. Otherwise, ACLS doesn't work. So why would ACLS not work in trauma? For the same reason that this particular heart that these guys are squeezing is not actually pumping blood. Because number one, the vasculature is disrupted. It's not connected to the heart in a meaningful way. Number two, there is no blood volume to sort of circulate. And we don't know about the valves, but they sort of don't really matter in this case. But this is essentially what we're doing in traumatic cardiac arrest. We are squeezing largely an empty heart, or at least a heart that's non-functional. So traumatic cardiac arrest is different. Some protocols bring this up. This is from Southwest Ohio. But we do mention in here that cardiopulmonary arrest as a result of trauma should be treated differently than primary cardiac arrest. And I'll just keep calling it primary cardiac arrest to be medical cardiac arrest or cardiac arrest that might benefit from ACLS because, of course, we'll say that they're different. And why they're different, again, makes a difference because of why you died. Again, in primary cardiac arrest, we think of the pump stopped working. You're not getting a pulse because it's just not there. Now, you can certainly have times when your heart is beating, but your brain is non-functioning in primary or medical cardiac arrest. But what we primarily think of for ACLS type stuff is that the heart has stopped, and as a result, everything else has died. It's a little bit different in trauma. So why would ACLS not work in trauma? Well, it all has to do with why there's a problem, why your heart has stopped beating. So the primary causes of death in trauma, at least around the United States, number one is going to be TBI. It's a little bit more if you die as a result of penetrating trauma, you have a better chance of dying from hemorrhage. But for the most part, it's going to be traffic accidents and falls and that kind of stuff. And the primary cause of traumatic death in the United States is going to be traumatic brain injury. Next is going to be hemorrhage, and then somewhere in there is going to be chest trauma. So the pneumothoraces and that sort of stuff. And then you got a smattering of about a third, a quarter of all the other deaths come from secondary things later on down the road, multi-organ failure, pneumonia, or other, just kind of generally other causes. But TBI, bleeding, and chest trauma are the ones we kind of think of in the field because those are the approximate immediate causes that we may be able to do something about. As such, the trauma arrest protocol, at least the ones that we're referencing here, again, this is Southwest Ohio, tend to focus on fixing that sort of stuff. So when you do the trauma ACLS stuff, you want to control the airway and ventilate right away. You want to decompress the chest to relieve tension pneumothorax. You want to control that hemorrhage and give volume back. And at that point, after you've done those interventions, you can apply a monitor to the patient, because again, the problem is generally not a primary cardiac issue. It's generally not a primary pump. There's the occasional time when it is, if you get like shot in the heart or something like that, or you get a blunt cardiac contusion where you go into VFib. But for the most part, it is something other than the heart itself. So only after you do all these other interventions should you actually apply the monitor to make any kind of determination about chest stuff. And by the way, even if you recognize the patient is in VF right away, why do you get to VF? Well, it's probably because of one of these other things up there that caused him to do it. And so you still got to fix that thing before he's going to get better. Now, you notice chest compressions I've listed at the bottom here, because chest compressions, again, if you're squeezing an empty heart or a non-functional vasculature or something that's blocked by tension pneumothorax, it's probably not going to get better. So you should do this other stuff first before you jump into chest compressions, or not that it has to be sequential like that. If you got somebody that can do chest compressions, okay, it's probably not going to hurt. But if you only got 2 guys doing it, then you probably need to put somebody on the airway and then the other person doing the procedures. And not worry about the chest compressions. Again, totally different than primary cardiac arrest. And again, if you got 12 firefighters all standing around, somebody can do chest compressions, that's fine. But prioritize the other stuff above the chest compressions, and certainly above the application of the monitor, because you got to fix the other stuff first. Now, you may bring up the case, well, what about the guy who we note was stopped at a stoplight, clutches his chest, kind of slumps over on the side of the seat, and then rolls into the car in front of him or something like that? What if we think it didn't seem to be really trauma that caused this? Then yes, in that case, it may behoove you to treat this as a primary cardiac arrest and do the ACLS type stuff. Prioritize chest compressions and shocks, maybe give epinephrine if you think that's a thing, all that kind of stuff. That's cool. We probably all kind of know that, but you do have license to do that. What about expanding all that stuff out? Because the one thing you didn't see when I started talking about the management of cardiac arrest after trauma, the one thing you didn't see was drugs, epi, bicarb, calcium, atropine, all that kind of stuff. That's not listed anywhere in there. And there's probably a reason for it. There is at least some controversy about the use of any sort of vasopressors in traumatic cardiac arrest. And primarily, though, that assumes one specific thing, and that is that if you are bleeding, that when you give vasopressors, you bleed harder, or it doesn't really help because you're still bleeding and you still just don't have volume. And so what you actually need is volume and resolution of whatever is causing you to bleed, control that hemorrhage, before vasopressors are going to actually help you. And that's a reasonable thing to think. But one thing that's sort of important here is when you look at the scope of what causes people to die as a result of trauma, at least in the United States, hemorrhage is there. It's absolutely there, but it's definitely not number one. Chest trauma is definitely not number one. These other ones we can't really do a whole lot about to start off with. The primary cause of death is usually traumatic brain injury. You smash up your noggin too much. And that is not really accounted for by a lot of the other stuff, a lot of the interventions that we just sort of talked about. Chest trauma, yes, we're decompressing the chest. Bleeding, yes, we're controlling hemorrhage, we're giving volume. Airway, at least a little bit of stuff. But TBI, like, what are we doing about that? And for that matter, what makes you die as a result of TBI? And this is kind of that one instance where ACLS might work in trauma. Might. Now, you should still do the other stuff, of course, because it's going to be hard to say that it's not bleeding or not chest trauma, but the TBI part is the thing that maybe a little bit of the ACLS stuff would sort of work. And what's the reason kind of behind that? Well, if you think about why your heart might stop after you have a traumatic brain injury, if it's primarily traumatic brain injury and you haven't like lost an arm or something like that, what's the mechanism for your heart actually stopping? Well, it could be that you're herniating and you're compressing your respiratory center and you're either not breathing, you're not oxygenating, that kind of stuff, but you still have intact vasculature and an intact heart. Or it could be that it's pushing on your cardiac center, or you could just have so much vagal tone that you become bradycardic and you don't perfuse enough and then you die. But again, the problem is that the control center is off and not the problem with the heart itself. The stuff that we talked about, the vasculature, the volume, and the valves are still mostly intact. Now, one thing with CNS injury in trauma is often you can get, as we've sort of seen when they talk about like neurogenic shock, you get cardiovascular collapse. I mean, just basic dilation of your cardiovascular system. Everything opens up real wide, and that warm shock that's so widely talked about. You do get just collapse of your vascular tone with severe TBI, and that can cause it too. Like that severe hypotension just results being so vasodilated. That's definitely a thing that's out there as well. But that might be something that you can actually fix with some of the ACLS stuff. Because again, you have the intact vasculature, you have the intact valves, you have intact volume. You can have some bleeding in your brain, but that's not going to be, liters and liters and half your blood volume. That's going to be 400 mLs or something like that at the big ones. It's not going to be that much volume that's actually lost. And so vasculature, valves, volume, it's all intact. Maybe we can treat this more like we would a primary cardiac arrest. I would pose for your consideration my sort of order of operations, things that I think would be important in traumatic cardiac arrest, which again is a little bit different. So, number one, chest compressions if you got them. If you don't got them, then it's okay. You don't really have to worry about it too awful much. We want to control the airway and ventilate in one way or another. Could be with a bag, could be with an eye-gel, could be with an ET tube, whatever it is. Control the airway, ventilate and oxygenate. Don't screw around. You don't have to get the tube. A bag valve mask works just fine. We should decompress the chest if there's any chance they have a tension pneumothorax, which there's almost always a chance they could have a tension pneumothorax, except maybe in the one case, which we'll talk about in just a second. We should control hemorrhage, and we should give volume back to try to supplant any of that. And we should then, after all that other stuff done, apply the monitor and think about making a transport decision based on it. And if it's bradycardia or asystole, after you've done these interventions, there's not a lot of hope, and it's probably safe to call it at that point. If it's VFVT or a regular rhythm, and maybe even tachycardic, that's a heart that still has some juice left in it, and we need to probably transport that guy. There is, again, one caveat, which I sort of mentioned before, that I think you have to ask yourself at that point. After you've done these other interventions, after you've made sure that everything else is squared away, you may ask yourself, is this an isolated head injury or a mostly isolated head injury? And if it is, then I would strongly consider 1 or 2 doses of epinephrine. And when I say mostly isolated head injury, maybe it could be C-spine, like upper C-spine or something like that. That's an obvious injury. Something like gunshot wound to the head or obvious gray matter exposed or something like that with no other marks on them suggests maybe this is an isolated head injury and maybe that's what caused the person to die. And in that case, I consider 1 or 2 doses of epi. Now, not epi every 3 minutes times 12 doses or however many, and not chest compressions ad nauseum, but consider at this point that the person's primary problem may be that they have such essentially collapsed vascular tone that they're just not able to perfuse anymore. And so if we're able to get a little bit of tone back into their vasculature with a dose of epi or 2 doses of epi, and able to do some chest compressions at least long enough to get the patient into a sort of life support mode, then the person may do better. They may actually come back, and that may be worthwhile. Now, there is a really, really important question here. And that is, if you have smashed up your brain so much that it's caused you to go into cardiac arrest, what's the chance that your brain is going to be okay and that you're going to return to a normal life? And even if we do that, does that really help anything? If you look at studies of epi and traumatic cardiac arrest, it does increase the chance of ROSC. Absolutely, but it doesn't increase long-term survival. We see that here. You see the same thing here. It does not improve 1 month survival. It does increase the chance of ROSC. So why do it? If the person's not going to survive, we always talk about their CPC score or a modified Rankin score with good neurologic function when the person walks out of the hospital. And we say that's really the standard. That's what we should be going for. We shouldn't do things that don't do that. There's, again, a little bit of a difference in trauma versus the medical patient, the primary cardiac arrest patient. In the traumatic patient, if it is isolated brain, that means there's a lot of other potentially good stuff in there. That's a person that may be able to be an organ donor to help somebody else, which you don't often find in the patient that has a medical or primary cardiac arrest. But an isolated brain injury that responds relatively well, and they do, you give these guys a dose of epinephrine or 2, and they tend to come back if they're going to come back. When you do that, you do actually you give them the chance to maybe go on and be an organ donor. And you may say, well, again, survival, 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 no benefit, no benefit. Well, look at what the endpoint is. You have to get ROSC in order to potentially be an organ donor, but you don't have to necessarily survive for 7 days in order for it to happen. And in fact, most of these guys with devastating head injuries, you're going to they're probably going to withdrawal care before you get to that weekend or something like that. Maybe not all the time, but a lot of the time. Likewise here, you don't need the organ donor to be able to survive for a month. We need to allow them to survive for a couple of days. And again, in most of these cases, if it is actually futile, then they probably would withdraw care at that point. But you can't withdraw care, you can't be an organ donor if you didn't get ROSC to start off with. But I think everybody deserves the chance to be a donor. It is a tragic circumstance, of course, and, you know, to some extent, I hate to be sort of existential about it, but there's nothing I can do about that. You may say, well, it's cruel to keep somebody alive just so you can harvest their organs. Well, look at it this way. I didn't cause their cardiac arrest. I didn't cause their car accident. I did my absolute best. I decompressed their chest. I managed their airway. I gave them volume. I splinted everything that I could. I controlled any sort of hemorrhage that I could, and the guy just didn't come back. We didn't get the best endpoint that we wanted, which is that the person walks out of the hospital and goes on to survive and live a normal tax-paying life or something like that. But just because we didn't reach that best endpoint doesn't mean that there's not a better endpoint than just dying, than just stopping. And that is where donation has a big potential. So even though we didn't get exactly what we wanted, survival, neurologically intact survival, yes, absolutely best. If we can't get that, I would rather have donation as an option, even a potential option, than to completely withdraw and say, we're just not going to do it. Everybody who didn't reach that point is dead. Now, I think a really important point is that it's going to be hard to protocolize this. You could say, well, if they have a primary head injury, then maybe it's worthwhile to give them a dose or two of epi and see if they come back as a result of it. Now, I don't know if that actually, broadly speaking, because you're not going to increase survival, I don't know if that, broadly speaking, is really kind of the right answer. I think it's very specific, and I don't think this is really a technician-level decision. It's not something that can be protocolized well, but that's why we want paramedics to not just be technicians, but to be providers, to be thinkers, to be folks that can take the whole situation in place and make a decision based on everything available and synthesize something instead of just spitting back out what's in a protocol. You got to be able to do that if you're going to think about some of this stuff, but you got to think about this stuff, so you got to be able to do that. So, long story short, everybody, in my mind, deserves the chance to donate to better somebody else's life. And there is nothing immoral about giving somebody that chance. So if you can resuscitate somebody, if there's something we can do for these folks, see about it. All right, so to sum up, medical cardiac arrest is not the same as traumatic cardiac arrest. They have different mechanisms by which people arrest, and subsequently different treatment priorities, and those priorities are almost completely reversed, and you have to know the difference between the two, and you have to treat the two differently if you're going to make any headway. And when you do that, you do find that people actually get better, and traumatic arrest is not the absolute death sentence that we sort of have always thought it is. It becomes more in line with like the survival rate after medical cardiac arrest. Epi increases the chance of getting ROSC. Sometimes ROSC is enough. Sometimes it's not. And that is maybe a tailored decision for each individual person. But do keep in mind that even though we sort of decry ROSC as an endpoint in a lot of studies, there are some times when really what you need is ROSC as the first step to give the person the next shot. And if there is something that is in between neurologically intact survival and simply calling the code, maybe that other endpoint somewhere in the middle is a reasonable thing to aim for as well. So, again, always follow your local protocols and the direction for your jurisdiction. This is presented as information and something to think about.